Hi, I'm Garnet Gilmore, the Marketing and Sales Director at Warwick Forest, your lifelong learning premier sponsor. Today we're filming from our beautiful grounds. Behind me is the putting green, and over here we also have outdoor dining under a pergola, walking paths, fountains, ponds. It's a beautiful campus, and we've won the Newport News Green Award as well. We'd love to show it off to you, so call us today and come in for a tour. I'm introducing Dr. McCoy. Dr. McCoy earned her medical degree from Duke University School of Medicine. Dr. McCoy completed a general surgery internship and urology residency at the Medical University of South Carolina in Charleston. She also holds a Doctor of Philosophy and Biomedical Engineering from the University of Virginia. Dr. McCoy is board certified by the American Board of Urology. She enjoys practicing personalized medicine. When creating a care plan, she takes into account the whole patient, including their family dynamics, home environment, and personal goals. Dr. McCoy specializes in the diagnosis and treatment of male and female voiding dysfunction, pelvic organ prolapse, stone disease, and erectile dysfunction. Dr. McCoy grew up in Chesapeake, which explains why Hampton Roads is near and dear to her heart. She has a special appreciation for the area's natural beauty, people, and festivals. Outside of work, she enjoys family time, hiking, eating, and watching old films. Dr. McCoy is married with 2 children.
Now, just going into, a little bit more about the anatomy and why we know what we know about the urologic tract and when this was established. The anatomy of the urinary tract wasn't really first documented, at least that we can tell, until about 129 to 216 AD. Galen essentially was the first to detail the anatomy of both humans and animals, and we begin over time to improve upon these sketches and these anatomic detailed visualizations. This was not improved upon until Andreas Vesalius in 1543. And it's interesting, he described what they call the anti-reflux method. So generally, in a normal case, the urine would, after filtering blood from your main vessels into the kidneys, the urine or the waste product would be produced, drained down into the ureters and into the bladder and be excreted. It's this key focus on the ureter draining the urine into the bladder that he was able to describe. Essentially, there's a tunnel of that urine tube into the bladder, such that once the urine's in the bladder and the patient's squeezing their bladder down, that urine generally should not propagate backwards up from the bladder into the ureter. Some children are born with this, and commonly you'll see in those individuals prior to repair, if it's indicated, some eventually grow out of this. If repair is indicated, what we do, if the ureter isn't tunneled far enough into the bladder, is essentially we pop those urine tubes off surgically while the patient's asleep and comfortable, and we reestablish a tunnel such that that urine isn't able to reflux back from the bladder into the kidney tubes and up. And why do we even care? The reason we care is essentially you may place that individual at risk of high pressures to the kidneys that may over time damage them, or repeat infections. Initially, there was a thought that repeat infections due to these reflux events could cause scarring, but now the focus is more on just the insult or comorbidities of having repetitive infections and how that can affect the overall individual. So it's interesting that they were describing this as early as this time in 1543. It wasn't, or we start to see Leonardo da Vinci's sketches of the urologic system a little bit later into the 16th and 17th century. But what was actually interesting about him is that these anatomists did not perform commonly human dissections, and what they would often dissect or what livestock was around, often it was cattle and bulls. And it's interesting, in Leonardo da Vinci's sketches, he did not depict the prostate often, or often it was very hypertrophic. And if you can imagine, as shown down here in the bottom right hand of the screen, the bladder essentially goes directly into the urethra. However, in a male human patient, there would be a prostate depicted immediately underneath the bladder through which the urethra passed. And that was not detected, and I wondered why. And the interesting answer to that is these bulls were often castrated. So you're taking away the powerful testosterone function or the testosterone drive that may cause that prostate to grow. So in the absence of that testosterone, which 90% of testosterone is created by the testicle, another 10% by the adrenal glands. If you take away that testosterone drive, then you develop a hypertrophic or atrophic prostate. And it's interesting. Now we've manipulated that whole concept. Some of the medications we use now to help shrink a prostate for a male patient that may be having some difficulty emptying his bladder may also cause decrease, obviously, in the potent testosterone or the more powerful testosterone function. And that's something we always make these patients aware of. Being on these medications may help your urinary symptoms. However, if they're depressing testosterone, it may also deprive or cause changes as a result of lower potent testosterone, such as erectile dysfunction. And so that's something we always have to make sure we're making our patients aware of. Now, just to next change gears, we've gone a little bit over the anatomy and history. I want to really focus on voiding or the process essentially of urination. And we'll talk a little bit about some of the pathophysiology and science behind that. And then we'll jump into common ways that this can go awry. I find several patients may have one or many of these simultaneous comorbidities or issues that may resultantly lead to urination problems that they may have not been aware of could lead to that. Now, the science or the process of micturition or voiding, aka urination, involves essentially three major steps from a bladder and urethra perspective. The first process essentially is inhibiting signals to the bladder that would cause it to squeeze. So inhibiting, these are special nerve signals, parasympathetic signals. So by inhibiting that, your bladder is able to relax and just sit there and store. And that's what you want during the filling phase. Also, simultaneously during this filling phase, you're activating receptors on the internal sphincter, which is where the bladder kind of funnels down into the urethra, this essentially balloon neck. You're activating receptors here to cause it to squeeze down and not relax. So this is allowing for increasing a little bit of resistance there, again, to promote storing. Also, you're activating signals around a muscle that, if you can imagine, it's coming in and out of this screen, kind of wrapping around the urethra, your external sphincter. And that is essentially your voluntary control to squeeze your floor, your sphincter, and no, I'm not going, I'm still in the storing phase. During when it's time to actually go to the bathroom and void, we have the opposite essentially. So to the right hand, what you have first as a signal is stimulation of your parasympathetics as well as inhibition of sympathetics, which just means you're inhibiting that resistance at the bladder neck to allow that to funnel open, and you're stimulating or activating what was previously inhibited in the actual bladder wall, so that balloon can now squeeze down. The very last step to occur, which is why many of us are able to some extent, when you do feel an urge, control it, is volitionally. The last step to occur is you tell your sphincter to relax, such that when you're in a socially appropriate place, for most people, younger people, you're able to relax that. However, as we age, we lose that, or after children, or over time, it's not uncommon for some of these signals to get rewired, and for us to lose some of that ability there, especially of the sphincter, or for us to have, without reason or cause, overactivity of some of the signals that are received in the bladder. So we'll talk a little bit about why this occurs. And again, one thing I do want to stress, it's more common than everyone thinks. It's just something we just don't talk about often. This is just another depiction. I thought this was a little bit more impressive schematic from a common illustrator that we used in medical school, demonstrating the bladder with its muscle fibers on the inside, how the bladder neck funnels down, and essentially this is your internal sphincter, and then coming kind of on the sides here, if you can imagine, again, this wrapping in and out of the screen, our external striated sphincter, and that's our mechanism of control. Now, the bladder, at least in most cases early on, I should say after potty training in a child, bladder just doesn't get signals by itself. The main control center is the brain. That's what's responsible for sending, after we're potty trained, that's what's responsible for sending and receiving signals to be able to tell the bladder how to behave. Now, while a child is early on developing prior to potty training, the signals do actually go between the bladder and the spinal cord. And this just reflexively, when that bladder is full, reflexively that bladder will contract the internal sphincter, that neck will relax, and the external sphincter will allow for that urine to escape. But after training, potty training, we develop a little bit more of the frontal cortex of the brain, and essentially the voiding center control in the brain to know, hey, it's socially acceptable to perform these habits here and here, and that begins to take control. I won't kind of delve too much into the weeds here on the different nerve regions, but essentially that's how it forms. After training, our brain begins to take over and allow for control of when it is acceptable to empty our bladder and when it's appropriate to store. I want to talk a little bit about different, we'll jump into varying common conditions that could lead to different urinary pathologies. Please feel free to, again, jump in at any point and ask me to clarify things. This slide is a little bit old, but it does still hold today. That stroke is a common cause. Yes, and so I got a question about perhaps why an older, a near adolescent may be still wetting the bed. There are still, after they have learned some habits, I should say, they aren't performing these matters on purpose. They still have control, but perhaps there's some pathology there, not only involving the bladder, but we find also the bowels, where some of these signals or signaling need to be retrained, and some of the older children that may still have issues with bedwetting. And I don't particularly specialize in pediatrics, but I was heavily involved with it prior to leaving training. One thing we commonly do there is pelvic floor training, relearning. Sometimes we perform after we ensure that there's no problem with the kidneys, bladder, labs, and there isn't any some other chemical cause for this. We essentially retraining the bladder to relearn with the brain and the spinal cord, relearn these habits, again, making sure there's no issues of abnormalities in electrolytes, spinal cord abnormalities, nerve abnormalities or bowel abnormalities. And the bowel does play a big role into how well we learn to appropriately void as well. So constipation does play a big role, or management of that into that patient population. And I'm happy to get a little bit more into that if that didn't answer your question. And so with regards to stroke or cerebrovascular accident, unfortunately, the southeast of the United States not only is the stone belt, but it is also the stroke belt, with quite a number of strokes in this region. It was at one point, essentially 10 years ago, the second most frequent cause of death. Now with COVID, we unfortunately have new reasons, but not only does it cause significant changes in the individual with regards to weakness, inability to perhaps speak, swallow, because anything that affects the main center in the brain will affect subsequent organs. It also affects the bladder. And what we found in researching this a little bit more is that immediately after a stroke, an individual, and about 25% of individuals may suffer from what we call an acute shock phase, which may last anywhere from 6 to 12 weeks, where they're essentially in retention. There's a spinal cord shock and everything just fixes in place. The sphincter fixes closed, and the bladder is areflexic, which means it does not squeeze. So the bladder is not squeezing, so you're just in a state of storing. The sphincter is not opening, again, promoting a state of storing. And what we find in these individuals, some few weeks or immediately after their stroke, is that they may require a catheter, a Foley catheter, for a brief period of time. And yes, anesthesia and some pain meds immediately after certain surgeries can also lead to acute urinary retention. That was one of the questions. Can anesthesia cause retention? Let's see, I will try. I may answer some of these at the end here, so please, I'm not ignoring you. I do kind of want to follow with some of the slides here. And blood tests that may impact the kidneys, or that may tell you a little bit more about the kidneys. Something providers will commonly get are basic metabolic panels. Also, a complete metabolic panel would look at both the kidney function and the liver function. So sometimes we'll look at that all together if you want to get more of a whole measure. Obviously, inspecting the urine, all of these things together give you a sense of, just from looking at the blood, the kidney health. More measures that allow us to look at the health of the kidney include imaging, such as ultrasound, plain x-rays with certain dyes, or CT scan. But yes, these are excellent questions. And so right after a stroke, you have the acute urinary retention phase. It takes time generally for that to resolve. And what unfortunately we find is that in the delayed phase, we start to swing in the other direction, or swing into the other side of the spectrum, where the bladder becomes hyperreflexive or overactive. And we find for these patients, unfortunately, and after trialing conservative options such as reducing the amount of bladder irritants like caffeine, sodas, that these patients may need to take an oral medicine to calm that bladder down and relax it a little bit, essentially acting on that first phase or image of those receptors to relax the bladder, promote the storing phase. For those patients that do not benefit from these oral agents, we do perform measures such as Botox injections in the bladder, which, similar to, essentially to a sense, paralyzing the wrinkles in my forehead or what have you. It also helps to reduce the bladder spasms as well. But just for a brief period of time, Botox does eventually wear off. Moving on, the next disease, Parkinson's, is something that people don't commonly realize can cause urinary symptoms, but strangely, one of the signs that we may see first with Parkinson's are urinary problems. But what happens is with cell loss within the substantia nigra, which is an area in the brain responsible for regulated movement, what happens is with cell loss there, the bladder begins to develop increased cholinergic activity, essentially all to say becomes hyperactive, becomes hyperreflexive, and you'll have events such as urgency, frequency, without much warning in these individuals. And what we'll commonly do as a treatment after, I'm sorry, move forward too quickly, after appropriate evaluation, and as long as we're making sure there are no other issues going on, such as infection and what have you, after appropriate evaluation, we'll trial a patient on for physical therapy or conservative options like reducing sugar, caffeine, bladder irritants. If that doesn't work, we'll trial oral medications to, again, calm and relax that bladder down. Moving on, multiple sclerosis, again, anything that is affecting the nerves in any way, you're affecting the signals or the pathway for those signals or the cables between the brain and the bladder, that can also affect the bladder. So multiple sclerosis, which tends to be a demyelinating disease, essentially you're losing the insulation for your cables, so you're not able to or not appropriately having signals conduct. You're losing this insulation because the body is attacking, it's an autoimmune disorder, attacking that insulation for the cables, because that can eventually damage the nerves or damage that insulation and therefore affect the signals. These individuals commonly will experience symptoms such as overactivity, and just kind of going or kind of categorizing this further, often we find two main categories of cerebral or at the main brain multiple sclerosis or spinal multiple sclerosis. Most lesions occur within the cervical spinal cord, within the neck, and what we see commonly is overactivity, urgency, frequency, gotta go, I don't have time to make it, and sometimes sphincter dyssynergia, which means when that bladder is squeezing, that sphincter is supposed to relax. But in this case, with the dyssynergia, they're fighting one another. And we worry when this happens that if there's a pressure propagated by this balloon in the bladder, and that sphincter is not relaxing to allow for a pop-off valve or mechanism for that pressure, we worry that some of that pressure may get propagated back up to the kidneys, potentially, and cause damage. So that's something that we're looking for when we're evaluating voiding dysfunction in our patients with multiple sclerosis. Again, after adjusting fluid and timing when you're going to the bathroom, we again provide oral agents to help relax the bladder. If that doesn't work, Botox is an option. Catheterization if needed, if there's concern for high pressures in conjunction with this medication to relax the bladder. But this is something that we would pick up on certain testing, and something we use commonly for most voiding dysfunction is something called urodynamics, which I tend to call it a bladder EKG. It isn't technically, but you're looking at that muscle activity of the bladder in conjunction with the sphincter, and you're studying the pressures and when it's contracting, and if that contraction is happening when it shouldn't be, and if there is no contraction happening when it should be. So that's kind of where we gather a lot of that actual data. And we'll kind of move quickly here because I do want to allow time for questions. Other peripheral nerve lesions, again, so a little bit further out from the spinal cord. Issues we see commonly are with patients with diabetes over the long term, 10 to 20 years. You can have issues when you have herpes. Those issues herpes zoster or shingles, I should say, those issues do tend to resolve after treatment, but it can affect it acutely. Pelvic surgery, if you're causing any movement around or traction on the nerves in the pelvis, that can cause issue, or lumbar or back disease. One good question someone asked, how much fluid should a person ingest daily? It depends. For my patients with heart conditions and kidney issues, I would say, that's going to be dictated by your nephrologist and your cardiologist. But in general, for those who worry about those big fluid shifts, on general, 2 to 2.5 liters a day of water, which I'm guilty. That is very hard to do. But as someone that treats kidney stones commonly and who sees people suffering from that, in general, our guidelines, urologic guidelines, recommend enough water to produce essentially 2 to 2.5 liters of urine, which means 2 to 2.5 liters of water going in. So that's a good question. With the diabetes over the long term, what we find are individuals, essentially if you're damaging or causing injury to those nerves over time, lose the ability to squeeze their bladder over time and may go into urinary retention. Kind of similar idea for pelvic surgery. Some individuals will go into a pelvic surgery such as hysterectomy and abdominal perineal resection for cancer in the rectum, or total exenteration, which means having to remove multiple major organs within the pelvis, such as colectomy, having the bladder removed, or as well the female reproductive organs removed. By causing traction or manipulating those nerves in the pelvis, you can essentially stun them and have or experience about 80% of people, the bladder's ability to squeeze it is lost. And that can occur for up to 6 months. It can be regained over time, but it's just something that following those surgeries, I do like to tell people, don't be discouraged. We may do some testing urodynamics to see how it progresses over time, but that is not an uncommon finding. With lumbar disc disease, similarly, you're a little bit closer to the main center or the spinal cord, but as these nerve roots come out from the main spinal cord into the back, they can get trapped and compressed, as well as irritated. If it's merely irritation, you're irritating or may cause changes in that signaling. You may have hyperreflexia, the bladder's just squeezing and you got to go to the bathroom all the time, urgency, frequency. If it's an acute compression, so essentially you're blocking that signal, the bladder may not work at all. So you may be in a state of retention, and that's something where, especially if you're having pain in the back, weakness in the legs, problems with the bowels as well, and bladder, that would lead us towards thinking, hey, there's something a little bit higher up in this nerve pathway that we need to look at, and you may need an MRI. But again, this is piecing together story along with symptomatology. Again, with shingles, what tends to demonstrate itself or manifest as very painful rash can also aggravate those nerves there, and resultingly, depending on the location, lead to bladder overactivity, but that does tend to resolve with treatment of the shingles. And then this is, and just kind of summing up, main urologic health, what I tell people, just in general, across the board, just the importance of hydration, appropriate diet for their urinary health, trying to, and again, I'm guilty of this, trying to avoid caffeine, sugar-laden beverages, things that may, for some individuals, spice or acidic foods may be irritants, for others not, but just being aware of how your body responds to these things. Exercise overall, not only for bladder health, but mental health as well. Managing current medical issues definitely does play a role for things as what may seem as mild or unimportant as obstructive sleep apnea, that can definitely affect someone's quality of life in that if you're not compliant with your CPAP and you have sleep apnea, your body sends a natural signal at night because it gets a sense that I can't breathe, I need to get rid of all this excess pressure. Your body sends out a natural diuretic and you actually produce more urine at night. So for my individuals suffering with urinary frequency and going to the bathroom a lot at night that have CPAP management, or that have obstructive sleep apnea, management with the CPAP and being compliant with that will help. Taking your medications as recommended. And, obviously I tell everyone, be your own advocate. I say it doesn't matter if you think you're annoying, it's okay. You're the one that's going to take care of you, and you know your body the best. We're just here to help you. So being your own advocate. Sometimes it means telling us things that you don't think maybe we should know. I say it doesn't help to kind of go down that pathway to let us know that information. And I'll open the floor to questions at this time, and to any questions that I didn't properly address, I'm happy to kind of go back to that. Okay, and one question was, could you discuss UTI causes and treatments? That's a great question. Fantastic. What I will say, it kind of depends, and I break it down based on the patient population. I find idiopathic or in some younger female patients within that population, they'll have frequent UTIs, and they're performing the appropriate hygiene practices, drinking water appropriately, going to the bathroom before and after intercourse, wiping appropriately. And they've done studies where they actually looked at certain features of bacteria. They have fimbriae, or little finger-like projections, and they find that some of those bacteria tend to stick, unfortunately, to some women's tissues more than others. It's not a matter of what they're doing, it's just something they've detected. So for that patient population, what I find or recommend doing is breaking the cycle with some kind of suppression treatment, if not something as mild as cranberry supplement or D-mannose, a medication that makes the urine a hostile environment, methanamine, or we may do a low-dose suppression antibiotic just for a few months to break the cycle, or just have them have self-start antibiotics if it's an issue of after intercourse. So in terms of the UTI causes in general, we often don't know in a young, healthy female, why they're getting UTIs if anatomy is normal and there's no other issues. Some other causes of UTIs are what I would call nidus, or sources of repeat infections, are kidney stones. If an individual, their entire workup has been cleared and we find there's kidney stones, they may be shedding bacteria on the surface of those kidney stones. Any kinking or drainage issue in that urologic tract may be responsible. So that means anywhere from the top of the kidney tubes all the way down to the bladder, or if there's issues emptying the bladder, if there's obstruction of the urethra, you're essentially creating a stagnant environment, and that can predispose someone to recurrent urinary tract infections. And okay, if you do not have sleep apnea, but have begun going to the bathroom more frequently at night, I guess, what should you do? I would, I always tell people, and I do it myself, it's important to establish a log. That always helps with anything, for myself, both personally and professionally, of what you're taking in during the day, the types of beverages, foods, what time you're taking it in. For some people, they'll be surprised that may be contributing. It could be some of the medications. If it's none of that, diet's fine and stable, you're not overhydrating or keeping many cups of water on your nightstand, And then that may warrant further evaluation by a urologist or your PCP, making sure they're checking your labs and making sure there's no abnormality there, no abnormality on physical exam that can cause it. And men, I find commonly it tends to be a matter of the prostate. If you think of the prostate as a dense donut under the bladder through which the urine has to flow, as men age, it's normal for the prostate to grow over time and that center of the donut closes. If that center closes, the bladder is unable to empty as well throughout the day, and that leads into the evening. You have weakening of stream, hesitancy, waking up a lot at night because you're not fully emptying your bladder. Okay. What common causes for UTI in the elderly? Again, I would examine the patient, look at imaging lab studies. If everything looks normal and unremarkable there, sometimes we don't find a cause, so no stones, no kink in the tract, anatomy is normal. Then we may do a suppression antibiotic and not necessarily know a cause. In my elderly female population, actually, a common cause is lack of vaginal estrogen, which happens after menopause. That can change the normal vaginal flora and allow for more bad bacteria to get into the urethra. They only have to go 3 centimeters. A female urethra is not that long. So that may lead to frequent UTIs in my elderly female population. If it's an elderly male, I'm looking more towards the prostate obstructing issue or looking more for other causes such as a nidus for infection, such as a stone or kink somewhere in the system. D-mannose tablets, that's a good question. I don't commonly use those, I'll admit, but there is literature on that it works. We just don't know, or we do know how it's affecting how the cell wall of the bacteria is protected. But in general, for those, I err more on the side of every day to every other day. I prefer cranberry supplements over that, or a short course of what I call methanamine with vitamin C to make the urine very acidic for like 1 to 2 months. What is a normal creatinine level? It depends on your muscle mass, but in general, it's anywhere, and depends on male versus female, from about 0.7 to 1.2. And I also tell people, look at their trends. So what may be normal in general, is one thing, but looking at your prior labs, if you've constantly been at a certain level and it may be just 1 tick above normal, but everything is well, as long as you're stable within your trends, that's okay. Can vaginal tissue dryness in older women be related to frequent UTIs? Yes. And again, that goes back to the lack of vaginal estrogen postmenopausal. So one treatment I do use, and I failed to mention this earlier, is topical vaginal estrogen, not oral systemic estrogen, but topical vaginal estrogen for a short course. And those individuals that don't have history of uterine, ovarian, breast cancer, the studies show that a very little bit is absorbed systemically that goes to the whole body, but I don't like to risk that. So in that patient population, I don't use it. Does a lot of acid within what we consume irritate bladders? It can. So there's a small population of patients that may have interstitial cystitis. And essentially, I think of it as some kind of autoimmune disorder of the bladder where the body's attacking the bladder lining that's compromised, and certain intake of irritants can essentially act as salt on an open wound within the bladder. So for that patient population, yes, but just in general for everyone, caffeine, alcohol, very high sugar products can irritate the bladder. People I know used estrogen creams, got cancer. While in theory it is safe in terms of topical application, it's not something that is taken systemically, and the literature shows that it can be used for quite a bit of time, but I do tend to, because of the theory that it can eventually lead to something, I do tend to use it only for a short course to break the cycle of recurrent urinary tract infections. But knock on wood, I haven't had any individual with an issue secondary to replacement topical estrogen creams for that short course for recurrent urinary tract infections. The next question, are there certain foods that can cause kidney stones? In general, kind of a blanket statement for kidney stones in terms of what an individual can do to prevent, I should say. Increase water or hydration at 2.5 liters daily, minimizing salt intake, minimizing animal protein intake. Actually, calcium, you want to make sure you get the appropriate amount, because if you have too little calcium, you can form a different type of stone. But for my stone formers, my repeat offenders, I always do a 24-hour urine collection on them to see why that patient in particular is forming stones, because it tends to be different for each person. And even for that same person, it may be different at different points in their life. Can sudden weight loss cause kidney stones? Technically, if you're causing swings or changes in the electrolytes, yes, but I haven't witnessed that. I do know with patients with surgical reconstruction for weight loss, such as gastric bypass, they do tend to compromise or use the small bowel. When you do that, you affect absorption of certain materials, and that can predispose to kidney stones. So when people come in and they tell me they've had a gastric bypass and they're having flank or back pain and blood in the urine, I'm looking towards that as a cause of kidney stones. But again, in the end, for me to know what an individual cause is, I like to do 24-hour urine collections in my patients that are repeat offenders or that have a really large stone, to know why that person in particular is forming stones. It looks at different urine electrolytes to know what may be super saturating in the urine, what are the stone, what's an increased stone former, and how much stone preventer they have in their urine, if that makes sense. Do I recommend a low oxalate diet for kidney health? No, I wouldn't say so, because again, different individuals, the most common type of kidney stone is a calcium oxalate stone, but different individuals, again, I lean heavily more on the 24-hour urine collection and not on, hey, if a patient has a calcium oxalate stone, we stop this in particular, because the urine may tell us a different story. And then I never like to tell anybody, cut anything that you love cold turkey. Some of the high calcium oxalate foods are almonds, dark chocolate, red wine, spinach, rhubarb. Some of those things are good for you. So unless you're eating a ton of that every day, I wouldn't cut it cold turkey, everything in moderation. And I can send through the moderator a website on good or different stone diets. Again, this depends on the individual, such as low oxalate diet, or for patients or people that have suffered from uric acid stones, diets there, but I can definitely send that link. And again, thank you. I think we've addressed everything there. Any questions that come up later, please feel free to reach me through Mackenzie Masterson or Miss Aisha Parks. I am grateful for for you guys allowing me to speak. And thank you for just allowing me to share my love for urology. All right, you guys take care.